Please, can we see it?
Yes, please.
Okay. Yeah. Treating breach presentation. So who can enlighten us on it? When we say breach presentation,
Your kids are
what does
just.
it mean?
Please, sister, is it the starting of the abnormal labor?
Yes. Hadia said we should start from the breach.
Okay.
Sisters, please, can you hear me?
Yes, we can hear you.
Yes, we can hear you.
Okay. Directive from Hadia was we are to start from the breach presentation. So she said we should discuss later on. She will join us. It's a group forum for discussion. So we are increasing breach presentation. Can anyone share her knowledge on it? When we talk about breach presentation, what does it entail? I'm listening. Hey, is it that my voice is not being heard at all?
We can hear you.
So I want us to share our knowledge on it. It seems the class is so fine.
We are putting our words together. We'll get back.
Okay.
I think breech presentation is when the baby's presenting part is the buttocks instead of the head.
Okay. Any other view?
It's also when the baby, the leading part of the fetus is the buttocks.
Please, I didn't get you.
It's when the leading part of the fetus is the buttocks.
Okay. Please, any other view? Okay, so when we say breech presentation, it's when the buttocks of the fetus lie over the pelvis of the mother and the head is in the upper pool of the uterus. Then it's said to be breech. As our sister said earlier, we have a size of presentation. We have the cephalic. Yes. That one is when the fetal head is presenting. But with the breech, is the buttocks that lies over the maternal pelvis. The fundus is the largest part of the uterus, and so it is usually occupied by the largest part of the fetus, which normally is the buttocks of the fetus and the legs. So, can you mention some of the conditions which will lead to breech presentation?
Twin gestation.
Hey.
Okay, what else?
Babies.
Polyhydramnios.
Please, can you come clearer? I didn't hear what you said.
Polyhydramnios.
Hello. Hello.
Sister, please, in order to
Very mature.
avoid this chorus answers, why don't you just raise your hand? She mentions your name, then you go ahead. Because people will come and they'll be saying the same thing at the same time.
Faustina, please, are you
Premature rupture of membrane.
Please, I said polyhydramnios.
okay? Faustina,
Hello,
Winnie,
sister.
are you around?
Hello.
Yeah, I'm around. Sylvia, I'm around.
I am sharing the screen to my phone. I can't see, so can you conduct it for me? Those that have raised their hands, can you mention their names for me?
Okay. Okay. Sister Hannah.
Yes. When there is premature rupture of membranes.
Okay.
Hello.
Hello,
So,
please, we can hear you.
sisters, please, with the answers that you are giving, when you give, then you explain a little bit for us.
Yes, because I don't understand how premature rupture of membrane will cause a breech presentation. I don't
Yes, so
understand.
when you answer, then when you give an answer, then you explain the physiology for us, please. Okay, so Sister Hannah, please, can we hear you?
Oh, right now I'm a little busy, so I'll explain it later, please.
Okay. So,
Okay, Sister Angela. Angela OPOKU.
So abnormal pelvic stool can cause, example like this one, biconvulate uterus. Since it's having only like the uterus is too small, or let's take example for android pelvis. You see, it's the pelvis is inadequate to accommodate the how do I even put it? To be presented with the cephalic. And so when I'll come back again. I've forgotten the explanation for that.
The biconate, I thought the uterus is too.
Hello.
Sister Hannah, please, your hand is still up.
Hello, we can hear you, please. A speaker.
Sister Angela, please, your hand is up.
Okay, this time around, let me take when they have multi-gravidia, you see, since the abdominal walls are too large, and because the woman have given birth to many kids, it becomes so large that the baby will be roaming, and so the part that can occupy the lower pool will be presented with.
Okay. Thank you. Mr. Mariama.
Sister, please, hydrocephalus and oligohydramnios. With the hydrocephalus, with that one, usually the baby's head is big. So once the fundal side or the upper pole is larger, the head is likely to be stuck there. Then when you come to that of the oligohydramnios, with that one, there's smaller, or there's a limited quantity of the lacqua. So baby cannot move.
Hello. Is it from my end or from her end? Sisters, please, can you hear me?
Yes, please, we can.
Can hear you.
Okay, so per what she said, the oligohydramnios, I think since the liquor is not that much and the baby can swim.
Right.
The network is bad.
Hey.
What is
He's playing with you. Oh, come. It can't tire. I can't.
So those of you leave your mic and mute. No, what's your problem?
Please, is someone talking? I can't hear anything. No.
Sisters, please, can you hear me? Sorry, my network took me.
I can hear you, but I don't know of the others.
Yeah, we can hear you.
Okay, sorry, I think I have a bad message. So we are looking at some of the conditions that can lead to a breech presentation. And it says abnormalities in the shape and contour of the uterus. Example by conduit at the placenta previa or other growth. So the biconduit, as the other lady said, for the explanations needed, I can't. So if anyone can help us with data, I will appreciate it. If not, unless when Hajia comes, then she throw more light to it. Please, does
Sister
anyone have
Victoria,
an
please, your hand is up.
okay?
Sister
Please,
Victoria, please, your hand is up.
Yes, please.
Sister Victoria, please, you can talk.
Okay, I wanted to bring one of the points.
Oh, okay.
Yeah,
Okay, please.
you know, when my sister said oligohydramnios, I think polyhydramnios can also cause breech presentation. Why? Because we know the babies that have a lot of fluid around them, it's easy for them to flip or turn, for them to flip and turn, thereby increasing their chance of being delivered as breech. That's what I also think.
Okay, thank you.
Okay, thank
Yeah,
you.
welcome. Thank you too.
Sister Rhoda. Sister
Sister,
Rhoda,
Yeah,
what's
hello.
up?
Yeah, please, can you hear?
Yeah, we can hear you.
Hello, sister, please can you hear me? All right.
Yes, can
Yeah, we
hear
I
can
you.
hear
wanted to
you.
also, all right, I wanted to talk about the premature rupture of membrane. My
Okay.
understanding is that, mostly in early pregnancies, with the scan that the pregnancy when they do, you see that mostly they report breech presentation because the uterus is so roomy. The babies usually lie anyhow. And then sometimes before 32 weeks, it happens that way. So if there's a premature rupture of membrane during that time, especially less than 32 weeks, and the baby is presenting with breech presentation, definitely the labor too will be in breech presentation delivery. Thank you.
Oh, okay. You're welcome. Sister Caroline.
Please, I would like to talk about the unicornuate uterus. We know that with the fetal head is the largest part of the fetus. So and we know the shape of the uterus, getting to the cervical part, getting to the cervix part, that place is like a small. So from the fundus, that is where we get the largest part. So the head would want to accommodate the large part so that the buttocks would accommodate the small part. So I think that is one of the reasons for the abnormal uterus. That is what I think.
Okay.
Okay,
Thank
thank
you.
you. Sister
Any
Adams.
other?
Sister Mariama.
Yeah, sister. Please, I
Please, you
want
can
to say
talk.
something about the premature rupture of the membranes. The sister who gave that point. Can we say it's a sign? Because premature rupture of membrane cannot be a cause for breech presentation. I'm suggesting it should be rather a sign of breech.
Please, can you explain?
Presentation.
Any other hand, Posty?
No.
Okay. So another point also says when there is amount of like when the amount of lichen is greater than the size of the uterus. So as my sister said with the polyhydramnios, And another point also says when the uterine cavity is too big for the fetal side. I think this one is self-explanatory. And another point also said when there is abnormality of the fetus, that is hydrocephalus. Sister explained earlier. So, can we know the actual causes of breech presentation? The first one that we mentioned were conditions that can lead to breech presentation. But this question goes for the actual causes of breech presentation. So,
Sister Christiana.
Please, we have twin gestation.
twin gestation. Okay. Explain. You guys can say something.
Sorry, okay, so just as we know, twin gestation, the uterus may be, okay, twin gestation, when you talk about twin gestation, it can be a cause of breech presentation in a way that now people carry one, now you are carrying two. So maybe the size of the uterus to accommodate the two fetus in utero will become a problem. So let's say with the movements and stuff like that in utero, it will end up one presenting with breech and the other presenting in cephalic. Although it is not all twin gestation that presents with breech and cephalic. Thank you.
You're welcome.
You're welcome. Sister Maufemo.
I wanted to throw more light on the twin gestation.
Okay.
With the size of the uterus, normally at the fundus is more spacious as compared to the lower part of the uterus. And so in twin gestation, one fetus is likely to present with cephalic while the other presents with breech, in that the space in the lower segments of the uterus, it's mostly not enough to accommodate two heads. And those that are able to come in cephalic for both twins, one will be well engaged, and then the other will be, the head will be very high, not within the lower segment of the uterus. Thank you.
You are most welcome.
You're welcome. Sister Christiana, please, your hand is still up.
Please, I'm sorry, I'm low.
Okay. Sylvia, we can continue.
Okay. So let's look at some of the causes. What Haja gave us. One is contraction of the pelvis. So when the pelvis is contracted, as our sister explained earlier, the lower part cannot contain a mass. So if a pelvis is to be contracted, I think so, since the breech is the smallest part, it will try to accommodate it rather than the head. And uterine tumors in the lower part of the uterus, multi-pregnancies, multiple pregnancies, placenta previa, hydrocephalus, polyhydramnios, large multiparity, where there is a lax uterine and abdominal margins, prematurity in early labor, and unknown causes. I think with the causes, we've explained some earlier, so there wouldn't be any need for the explanation again. Let's look at some of the varieties of breech presentation, or we will say types of breech presentation. Please, can we mention some of the types? When you mention, then you explain what it entails. It's a hand that ties of breech presentation.
No hand.
No hand.
Mr. Christie.
Please, footling bridge, a process whereby the fetus is presenting with the complete, like the feet, the legs.
Okay.
Okay. Any
Thank
other?
you.
You're welcome.
Any other hands?
No.
Hey, how many are we? How many join? So we have a complete bridge. We have a incomplete.
Sister Evelyn Compson.
Okay.
Yeah. With the types of bridge, we also have the frank bridge. And with the frank bridge, the hips of the baby is flexed while the knees are extended. Thank you.
Okay.
You're welcome. Mr. Gifty.
Okay, so we have complete or flexed bridge. With a complete bridge, the attitude is of complete flexion with the thighs and legs both flexed. Thank you.
You're welcome.
You're welcome. Mr. Victoria.
Sorry, what I wanted to say has been said already. The frank bridge.
You can
Thank you.
also say no. You can also say what you want. Maybe there will be a difference. So please say your point. Any other?
I think that is it. Because that one, the hip is flexed and the knees are extended.
Okay. Mr. Evelyn, please, do you want to talk? Or is the old hand? Okay, Sylvia, let's continue.
Okay, so when you look at the types of bridge, we have the complete one. And it says in this type of presentation, the attitude of the fetus is complete flexion of the limbs and the head. So with that one, the hips and knees are flexed and the feet are tucked in beside the bottom. Which I have the picture to show us through the. So with that one, the hips and knees are flexed. And the feet is tucked in beside the buttocks. And with that one is common in multi-para women due to the roaming uterine cavity. So this complete breaching is mostly occurs in multiparous women. So we have incomplete breach. So with the incomplete, it says there are 3 types of incomplete breach, and these are the frank breach, footling, and knee. With the frank, as our sister earlier said, with the types of breach, it presents with extended legs. The legs are extended and thighs are flexed, and the feet of the extended legs are usually immobilized on split. It occurs more common in primates who have firm uterine and abdominal muscles. This results usually in making a wrong diagnosis on palpation because the fetus with the splinting on its head is in one piece. We have another as footling presentation. And with this one or both feet lie between the buttocks. and the thighs and legs are not fully flexed. With the new presentation, the thighs are extended and one or both legs are flexed and the knee is lower than the buttocks. So when can we confirm a bridge presentation at what weeks? Do we confirm a bridge presentation?
At 32 weeks.
This time I will follow.
Please, at 32 weeks.
Okay, thank
So
you.
me, I want to know everything also. 32 weeks, I just can't take it like that. Can you explain further why at we confirm it at 32 weeks? Hello, it's Amaufemo. Please, are you around?
Yes, sister.
Please, can you throw more light to it for us?
At 32 weeks, we believe that the position baby will be coming with, baby would have assumed that position by 32 weeks. That is where the uterus is almost at the sternum. So baby assumes whatever position baby will be coming out with by 32 weeks. Thank you.
Thank you very much. Any other views? Any other views, sisters?
Let's continue.
Okay. So
Please hold on. It's
diagnosis.
Anita.
Okay.
And sisters, please, by that time too, we assume that the baby had become big. So around 30 to 32 weeks, it cannot turn to maybe cephalic position. That's why we assume that at 32 weeks, the baby cannot turn again. If the baby is at breech position, it will be like that. Thank you.
Welcome. I can see a hand up.
It's the same hand. It's Anita.
Okay. So let's continue. Diagnosis of breech presentation. Because of the possibility of version at about 30th week of pregnancy, a breech presentation is not important before 32 weeks. If the fetus remains breech from 32 weeks onwards, it should be regarded seriously. So it is diagnosed after 32 weeks. I guess we're okay with the explanations that our sisters gave. So
Sister Carol.
Please, with the explanation, you are saying after 32 weeks. So should in case a question comes and they ask that, like, when do we confirm the presentation? 32 weeks, 33 weeks, 36 weeks. Which one are we going to choose? Because it is after 32 weeks.
So I think it will be 32 weeks because per the explanation that she gave me, she said a breech presentation is not important before 32 weeks. So I think from 32 weeks upwards. So if you see 32 weeks, you can pick that one.
Okay,
Or
please.
let's wait for when Hajia cancer, then she throw more light to it for us.
No, it has been said already. So thank
Sorry, Joyce.
you.
Sister Joyce. Mr. Rejoice, your hand is up. So I can continue.
Okay, so I think Hadia has thrown more light to it for us with the types of presentation, the brief presentation on inspection, what you see, on founder palpation, what you see, during auscultation too, where you hear it. So let's look at the inspection.
Hello.
Hello.
Please, I work at the ANC. Recently, we had a case. The woman was breached at 36 weeks. Then at 38, she was still breached. Later on, it turned to cephalic. Then later, it turned to breach again. So this is your 32 weeks. I don't know. We have gotten exception at our place. So I just wanted to add it.
So the latter part, you said it turned to breach again. Or the client delivered when the client delivered, was it cephalic or breach? Hello, please, are you around?
I'm around, but there is a network. I'm saying the patient was 32, at 32 weeks, it was breach. Even at 36, it turned to transverse. Then later on, we palpated, it was cephalic. We even made her to go and do the scan, it was cephalic. But later, as at the time she was going to deliver, it was breach again. So if it's 32, sometimes diagnosing at 32 is not for all.
Okay.
I don't know whether you are getting me.
No, I'm getting you, but you said that the latter part too, it was breach again.
And tend to cephalic. So
Hello,
it's like
sister.
it tend. Hello.
Yes, sister. With this one, I think we should take the parity of the woman into consideration.
Yes,
okay.
she's
Maybe yes, she's a
Gravida 1.
multiparous woman.
No.
One.
Yes, she's Gravida 1. She has never gotten pregnant. She has never delivered.
Wow. Then I think we should
Hello.
we should wait for Hajia's to come and explain further first.
Hello.
Please, one at a time.
Sisters, please, one at a time. Hello, sisters, please wait. When you are called, then you talk. Sisters, please wait. When you are called. Sister Rejoice, please, you can talk.
Yeah, so that was what I wanted to bring up. Because like you are pegging the diagnosis of breach at 32 weeks. And so if at 32 weeks, it can still, to me, it can still turn, because looking at our case, it turned even 3 times after 36 weeks. I don't know whether you are getting my explanation.
Yeah, we are getting you. You see, to every rule, there's exception.
Okay, so I just wanted to add that exception.
Yeah, there is exception. Because we also had some at our facility. She was 34. She went for scanning. It was 34 weeks. But she came back in 2 weeks and it was cephalic. Meanwhile, the scan 2 weeks ago said it was breech. But she came back, it was cephalic, and she delivered cephalic. So to every rule, there's exception.
Thank you.
Please, the lady asking the question, I want to ask her a question.
Sisters, please wait till you are called.
The scan that confirms that.
Please, who is talking?
Sister Mary, please, you can talk.
People are talking. I'm actually already asking the question. Was it confirmed or it was during palpation that they find out that the leak was and then later on sent to cephalic with palpation, or it was confirmed with that?
Please, can you come clearer? We didn't get what you said.
I said that was it with scan that was confirmed or it was only palpation?
No, she said a scan. They made her to take a scan. The scan indicated a growth.
Sister Mary Boatin, please, you can talk.
Sister, please, with the case, no. At 32 weeks, the fetus, the position that he or she is presenting, no, he can't change again, okay? But as he said, in every rule, there are exceptions to it. And then moreover, no, we even said that sometimes when the uterus is so enlarged, for the fetus, the atmosphere becomes very conducive for the fetus, so he keep on changing itself. So that is, I think that was what happens in that case. Had it been that maybe the fetus was to be a very big one, he or she couldn't change again, but it will present with the position that it was presenting. So this one, it can be that it was the results of the uterus. It was very large, so the fetus has the opportunity to change itself. Thank you.
You're most welcome.
You're welcome. Sister Mercy. Sister Mercy.
Hello.
Hello.
Yeah, please, we can hear you.
Also, hello, can you hear me?
Yes, please.
Yeah, we can hear you.
Aside the fact that we are gaining knowledge on this ground, we also need to know that we are doing it so that we can also write our exams and pass. And as my colleagues have already said, at 32 weeks, that is what is stated. Breach is confirmed. It's just in one cases you see that 10 and 10. But in actual fact, after 32 weeks, when you monitor very well, most of the cases, they do not 10. So we follow the majority. But we know that there are exceptions when it comes to that. So let's just take the 32 weeks as we move with our exams. Thank you.
You're welcome. Sister Cecilia.
As one of our sisters already said, we are learning for the exam 6 and then what is used worldwide and which is accepted. So it is 32 weeks that is being confirmed that the baby is sick. Even there are some cases that you see that everything is pointing so odd that this
Sister Cecilia, please, we can't hear you. Sister Cecilia, we can't hear you.
Hello, please, can you hear me? Hello?
Yeah. Hello.
Yes, please, can you hear me?
But your voice is a bit low.
Okay. I think that is my mistake. Sorry for that. I said at 32 weeks, when you read according to all the it is at 32 weeks that is being confirmed. So I think you get a case that you get a case that the person changes again to another presentation afterwards. I think there are exceptional cases that we get. You can get cases that are very odd that you think that the person will end up by delivering normal SBD. So I think let's go by the guidelines or what it is nationally being accepted, so that we'll learn and pass and go our way. So that case is an exceptional case. Miracles do happen. So a bit mercy, sir.
Okay.
All right. Mr. Veracruz.
Sisters, please, with the scenario our sister gave, it can happen in small for date. When the baby is small for date, it is likely baby can turn and unturn anytime. In case of polyhydramnios, baby can also turn and unturn anytime. But we use the 32 because by 32 weeks, we assume that baby should be well grown and baby should be big in size as in per gestation. So baby should occupy the uterus in such a way that there is no room for baby to turn again. That is why we peg it at 32 weeks. Thank you.
Okay.
You're welcome. That's Cecilia, your hand is still up. Do you want to talk? Or is your first hand? So we'll continue.
Okay. So I think Hadia throw more light to how you get to know if the baby is presenting with the breech. I think during inspection, it says if in the front breech, the abdomen looks long and narrow. In complete breech, there is no definite difference from that of a vector. So during the complete, the abdomen looks like the vector one, but with the frank one, the abdomen looks long and narrow. On palpation, on pelvic palpation, a large, soft, irregular mass, which is the breech, can be felt. When you move it, the entire mass with the fetal trunk will also move. So when the fetus is presented with 8 buttocks, when you are palpating, you see a large, soft, irregular mass. And when you move it, the entire mass with the fetal trunk will also move. So we should take note. On fundal palpation, the head
Sylvia.
Yeah.
So please, there's a hand up.
Okay, please.
Sister Rebecca. Sister Rebecca. So I can continue.
Okay. So on fundal palpation, the head can be diagnosed as a hard, round, smooth ballotment mass. When it is moved, it does not move with the rest of the fetal trunk. Fundal palpation. Okay. On auscultation, the heartbeat is heard at the level which is above the level of the umbilicus because the fetal heart is further from the buttocks than the head. Mostly during auscultation, you wouldn't hear the fetal heart where you hear it at the vertex. That one, there's a slight difference. If anyone has an explanation to this or can throw more light to it, the person can say. Any views on it, or should we continue?
Please continue.
Okay, so during VE, when you are doing VE, how to diagnose a breech presentation, I said there will be early rupture of membranes due to a poorly fitting presenting part. If the breech is flexed, you feel the buttocks, the toes, or the legs in breech with extended leg, which is the same as frank breech. The anal cleft and the buttocks are felt. In diagnosis, the anus, it will be found to be circular and firm, and the sphincter will grip the examining fingers, and when the finger is withdrawn, meconium may be seen on it. I hope most of us have felt this thing before. Mostly during the you see that something will be solved when you use your hands and enter. Coming out, you see a meconium. Footling presentation. The foot or feet may be felt. The midwife should confirm a footling presentation and differentiate it from a hand by the following points. The toes are each from a same length. They are shorter than the fingers. The big toe cannot be easily moved from the other toes with the hands too or the fingers. The fingers are large. The middle finger is longer than the rest of the fingers. The thumb is well away from the fingers. With the foot, the sole of the foot narrows and is long. There is a heel bone. The foot is at the right angle to the leg. And when it comes to the handle, the palm is broader than the sole of the foot. The raised joint is not prominent. The hand is not on the same angle as the forearm. Okay, so let's go to positions of the bridge presentation. So with the positions, we have the left circle anterior. We have the right circle anterior. So please, when we say the left circle anterior, what does it mean?
It means the section is pointing to the left side of the mother.
Please, can you come clearer?
Okay, it means the circle, the presenting part, the circle is pointed to the left side of the surface's pelvis.
Oh, okay. What of the right one? The right circle anterior.
And so it's vice versa. Then that one is also pointing to the right side of the surface's pelvis.
Okay, so we have left circle lateral. That means the circle is pointing the left on the lateral side or what? Please, what does the left circle lateral mean?
Yes, you just confirmed. You said it's pointing to the circle is pointing to the lateral side.
Okay, so we have the right circle posterior. Then we have left circle posterior. The handle of left circle
Sylvia,
anterior. Yay.
please hold on. Someone's hand is up. Sister
Okay.
Justina.
Please, somebody answered when you asked the left sacral anterior. I didn't get what the person said. Can the person please repeat it?
Please, the one who explained it.
Hello. You said you didn't get the right sacral anterior. I
Yes.
said the section of the presenting part is pointed to the anterior part of the
Emphasis pubis.
Sister Cecilia, please hold on. Sister Josephine,
left,
please
you
mute
said
your
the
mic.
left.
Sister Cecilia. Sister Cecilia, please hold on. Sister Josephine, please mute your mic. Sister Josephine, please mute your mic.
Josephine Ankara, mute your mic. Josephine.
Okay, Sister Cecilia, please go ahead.
So that our sister was asking of is it the right or the left that she was talking?
I think of the left.
Okay, the left. That means the circle is pointing to the anterior surface, the anterior surface of the CCC at the left side. It's pointing at the left side of the anterior part of the CCC. So that's just the meaning of representation.
No, like what I also know is different. Like with the sacral anterior means that the sacral like the iliopectineal
Josephine Ankara, why?
0240 70 7971.
Please, the host
Hey.
should mute her. The host should mute her.
Okay. Please, let's continue. Please, someone was explaining the left sacral anterior. The person should continue.
Yes, I was saying that with what our sister was explaining, like what
Okay.
I know is that with the left sacral anterior, it means that the sacrum is pointing to the left side of the iliopectineal eminence. But I heard her mentioning specific pubis. That's why I wanted her to like to say it. Because when there's anterior, it's pointing to the iliopectineal
The thing
eminence.
is anterior. It's the posterior that is always pointing to the iliopectineal.
So the
Sisters, please, one
posterior.
at a
But this
time.
one is anterior.
Hello. Sisters,
This one
please,
is
one at a
anterior.
time. Hello, please, one at a time.
The anterior iliopectineal eminence. The posterior is the sacroiliac joint, and then the lateral is the iliac line. That's what I know.
Please come again.
When with left sacral anterior,
Yeah, please, we are listening.
Back of 5.
Please, the sister who was explaining the left sacral anterior should continue. Seems she's off. Okay, Sister Carol.
So please, whenever we are talking about the anterior parts, we mostly make reference to the iliopectineal eminence. So it's either to the left iliopectineal eminence or the right iliopectineal eminence. Then when we come to the posterior, it has to point to the sacroiliac joint. So either the left sacroiliac joint or the right sacroiliac joint. Then when we come to the lateral, it's the iliopectineal line. Yeah. So with the left sacral anterior, it means that the is pointing to the left sacroiliac eminence. Please, you get it, because it is anterior. We are talking about the its relation with the iliopectineal eminence. Then, when it is posterior, we are talking about its relation with the sacroiliac joint. Then with the lateral, its relation with the iliopectineal line. So it's either left or right. You explain it with its relation to those things. Yes, that is what our sister was trying to say.
Okay, thank you very much.
So it means with the left circle anterior, that means the circle is pointing to the left side of the iliopectineal eminence.
Yes, please. Yes.
Okay.
So that when it turns 1/8, it is going to come under the symphysis pubis. Then it comes out.
Okay.
Okay.
Thank you. Please, are we all clear now?
No, sister, we'll be glad if she
No,
could take it
sister, please.
again. Take mouse.
Okay. So,
Okay.
Sister Carol, please, can you take it again for us?
Sisters, please, I was saying that whenever we talk about the anterior region, we are talking about the iliopectineal eminence of the mother's pubis. So the iliopectineal eminence, either right or left, that is the anterior part. Then whenever we talk about the posterior part, we are talking about the sacroiliac, the left or the right. Then when we talk about the lateral side, we are talking about the iliopectineal line. So depending on what is being given to you, if right now we are talking about the breech, then with the breech, we know the sacrum is the denominator. That means that's the presenting part. So with the sacrum being the denominator, we are saying that left sacro anterior. It means that the sacrum is in the anterior region, but which place specific region, the specific part of the anterior region that it is. That is the iliopectineal eminence. So we are talking about the relation of the sacrum to the iliopectineal eminence, either to the right or to the left. So if it is to the right, it will be the right sacroanterior. If it is to the left, it will be the left sacroanterior. Then when we come to the posterior part, that is its relation to the iliopectineal, the sacroiliac joint. So if it is to the right, we will say that that is right sacroposterior. And if it is to the left, it's left sacroposterior. Please, do you get?
Yes.
So, are we okay now? Sisters, please, are we okay now?
Yes, please.
Okay. So, with the explanation that we gave, we can
Someone
relate.
said you should write it and put it on the page for us. Sister Carol.
Okay, so I think she'll do that. Okay, so
Okay.
let's go to the mechanism of the sacroanterior. The right sacroanterior. It says the line is longitudinal. The attitude is one of flexion. Position is right sacroanterior. This means that the sacrum is opposite the right iliopectineal eminence, as our sister explained, you know. So this one is throwing more light to what Sister Carol said. The anal cleft of the buttocks in the left oblique diameter and the vitro-anteric or this iliac diameter is in the right oblique diameter of the pelvis. And then the denominator is the sacrum, as she said earlier. The presenting part is the anterior buttocks. The engaging diameter is the basilar diameter of 10.2 centimeters. So the movement begins. As descent takes place, there is increased compaction of the fetus. I think in vectors is descent, but in breech it's compaction. The anterior buttocks meet the resistance of the pelvic floor first, and it rotates 1/8 of a circle along the left side of the maternal pelvis to the fourth, bringing the basilar diameter into the anterior posterior diameter of the outlet. The anterior buttocks pass under the pubis arch. The posterior buttocks sweeps over the perineum, and the legs are born as the buttocks curve upwards. That one is for the movement. So let's go into the restitution. It occurs as the anterior buttocks turn slightly to the mother's left side, with good uterine contractions and further descent. The umbilicus is born. The shoulders then enter the pelvis in the right oblique. So with the internal rotation. So with the mechanism of the left circulanterior, we have the first one is the contraction. The first one is the compaction. The second one is the rotation of the buttocks.
Sister Hannah, please mute your mic. Sister Hannah Yabua, please mute your mic.
Okay, so the other one is internal rotation. So with the restitution, it occurs as the anterior buttocks slightly turns to the mother's left thigh with good uterine contraction and further descent. The umbilicus is born. The shoulders then enter the pelvis in the right oblique. So with the restitution, the shoulders enter the pelvis in the right oblique. So we should take note of that. Internal rotation. The anterior shoulder touches the pelvic floor first and rotates 1/8 of a circle to the left side of the mother's pelvis to the front. Then bring the shoulder into the AP diameter of the outlet. The anterior shoulder passes under the pubic arch and is born. The posterior shoulder sweeps over the perineum, and the shoulders are born with the arm shoulder on the chest. So delivery of the head. The head enters the brim. The head enters the brim of the pelvis in the transverse diameter, occasionally in the left oblique diameter. If the head is well flexed, the suboccipitobregmatic of 9.5 centimeters will engage. If it is in incomplete flexion, the suboccipitofrontal of 10 centimeters engage. The head descends, and the occiput touches the pelvic floor to be rotated 1/4 or 2/8 of a circle to the front along the right side of the maternal pelvis to put the occiput under the pubic arch. Further descent continues, and the chin, face, and sinciput sweeps over the perineum to deliver the head by flexion. So I think with this explanation, when Hajia comes, she will throw more light to it for us. Please, can you all see my screen?
Yes, please, we can.
Yes, so. So with the explanations, I think when I that time you will appreciate it very more. Mechanism of please mute yourself for us. Why?
I think she's having a problem with her network. So please, if anybody have any question or any addition, you can bring it up as we wait for her. Okay, Star Rosemary.
And please, so it's like the slide that she's using is different from the one that they sent to the page. So I wanted to know how you can get the same slide.
It is the same thing. You just have to scroll down to page, I think 54 or so.
Oh, okay. Thank you.
You're welcome. Mr. Theodora. Mr. Theodora, please, you can talk.
Was it?
Yeah.
Was a hand up?
No.
Okay. So let's look at the cephalic version, reasons for cephalic version. So when we say cephalic version, what is it? What do we mean by cephalic version? Hello, sisters, please, can you hear me?
Yeah, we can hear
Yes,
you.
hear you.
We've been hearing cephalic version, we've been hearing. So what is a cephalic version?
Mr. Veracious.
Please, cephalic version is a process where the baby is manipulated through the abdominal wall to turn from breech presentation to cephalic presentation. Thank you.
You're
Okay, you're
welcome.
most welcome. Any other views?
Sister Lauren. Sylvia, you can continue.
Okay. Let me check, I think. Mhm. So, as our sister explained the cephalic version, I think we all get it now. So, reasons for performing cephalic version. The reason why we perform a cephalic version. I'm reading. This is a high prenatal and neonatal mortality. There is high prenatal and neonatal mortality and mobility rates in breech deliveries than in vector deliveries. This is because when the head is born last, it passes as quickly though the birth canal and rapid molding occurs. And we all know what rapid molding can cause. With the larger engaging diameter of occipital frontal passing through the birth canal, usually in an upward direction occurs, which can result in tentorial tears. If the head passes too quickly through the pelvis during delivery, it brings about sudden compression, followed by a sudden release of pressure on the fetal head. Rapid delivery brings about intracranial hemorrhage. Delays in delivery result in congestion of the various sinuses of the brain with anosmia, which will be seen as asphyxia at birth. The tentorial cells usually involve the great vein of Gallon and its 8 functions of the confluent as the sternum. This results in intracranial hemorrhage. If the delivery is slow, there will be compress on the fetal cord when the head enters the brim, and this will arrest the fetal circulation. The venous sinuses are fragile. Therefore, when there is anuria, they break. Therefore, whenever the delivery is rigid or slow, there will be intracranial injury. Another point also is there could be prolapse of the cord because of ill-fitting presenting parts, and also because the cervical os is closer to the breech and the umbilicus than the head. There should be premature separation. Another point, there could be premature separation of the placenta during the second stage. When the body is born, the fetal head can inhale and inhale amnistate with mucus and blood. Another point also is fractures and dislocation of the spine, the long bones of the arms and the legs, and the ribs can occur due to poor handling or difficulty in delivering the body. Another point, internal injuries of the liver or spleen or pancreas can also occur due to poor handling. We also have nerve injuries. Ehlers palsy can occur if there is too much pressure on the brachial plexus. We have muscle injuries also. When the shoulders are possibly dragged out, there could be tear or bruising of the sternocleidomastoid muscles, leading to torticollis. Bruises of the body and edema of the genital organs can occur due to pressure on them or congestion during delivery. Another point is intrauterine infection. The membranes rupture early due to poor fitting presenting part, which results in delay in labor and frequent vaginal examination to identify the cause of delay. This results in entry of organisms into the genital tract. And another point is postpartum hemorrhage, which can be traumatic or atonic. Traumatic due to severe lacerations to the genital tract and possibly due to boot scrape rupture of the cervix. Atomic due to chronic, prolonged labor and uterine extensions. So I think with the points that I read out, these are the main reasons why we perform a cephalic version, because if the baby is to be born with which there are so many harm that can cause the baby.
Sylvia,
Yeah.
someone's hand is up.
Oh, okay. Please, you can
It's not very anxious. It's not very anxious. Sylvia, continue.
Okay, so the reason why we must perform cephalic version is that we want to prevent all these injuries that will occur to the baby, not even the baby, to the mother as well. With the baby, there can be tentorial tears, which will lead to intracranial hemorrhage. Torticollis also can happen. And the mother too, there will be Ehlers palsy, all those things. And with the mother, there can be infection. So in order to prevent all this, we try to do a cephalic version so that the mother can be born through, the fetus can be born the cephalic presentation so that we can prevent all these injuries. If someone has an addition or subtraction, the person can also bring it on board. If not, then I'll continue. Is there a hand up? Kirsty? Hello, sisters.
Hi.
Sister Christy.
Yes, sister, please, I want to find out that with the cephalic version, is it all midwives who knows how to do it? And we have people who have specialized and perform that? Because I personally, I don't know how to do it. So if anyone has an idea and could teach us, I'll be glad.
Okay, me what I know is the doctors. I mean, I don't know if midwives also perform a cephalic dressing. So as our sister said, if you are on this platform and you've done that before, we can share your experience so that we can learn from it.
Yes. Oh. Afanye magara funa mo la funa lenye disturb mo juba ho manga be akwe ko. Nkele mu.
Is that Theodora? Please mute your mic. Sister Veracioous.
Sister, please, with Catholic version, it's mostly done by the obstetricians. Midwives are mostly not allowed to do the Catholic version. And then the reason why I even raised my hand is I'd wanted to suggest if we could go through the points one by one. Maybe when you reach the first point, let's try and see if we can explain what is written there. I think by so doing, we can grasp it very fast as compared to the reading. Thank you.
You're welcome. Sylvia. I think her network. If there's any other question. Hello, Sylvia.
Yay.
Please, my sister raised a point saying that you should read the points one by one so that we can explain it rather than reading them together.
Oh, okay. I think my network is 50. Let's see. Okay, so let me start with the point one. When the head is born last, it passed as quickly through the birth canal and rapid molding occurs. That one is for the point one. Mhm.
Hello,
So,
sister.
hello.
Please, with the first point, with my experience on how do you call it?
The
Okay,
what?
with the first point, yes, with the first point, when the body is delivered and then the head is the last part to be delivered, when molding occurs, in most cases when the head is well flexed, the molding occurs very fast and then the head comes out easily. But when the head is not flexed or when the head is not well flexed, that is when you have the problem. That is when you have to locate the chin and then help to flex the head in there for the head to be able to be born. Thank you.
You're welcome.
Oh,
Please,
okay. Thank you. Mr. Carol.
Please, with my opinion, we know that it's the delivery of the head that is mostly a problem. That is when there will be delays. But once the head is delivered, we know that delivering of the body takes some few minutes or some few seconds for it to come out. So I think it has to do with the breech too. Once the buttock is delivered, the rest has to do with the body and the head, and it will also come out as fast as the body and the bottles would have been delivered in the vertex position. So the head would have to mold very fast so that it can also pass through the birth canal and come out. That is what I.
Oh, okay.
So,
So I think we should move to the next point.
okay. With the larger engaging diameter of the occipital frontal passing through the birth canal, usually in the upward direction, okay, which can result in tentorial tears. So with that one thing, as they explained, the body has come out. So the head needs to be born early so that it wouldn't cause any fetal hypoxia and all those things. So if the head is not well flexed, you have to go in, adjust the chin and all those things. When the rapid moldings and all those things occur now, I think various sinuses, there will be tear of the various sinuses. That's what I understand with concerning this point. I don't know if one has a different explanation to it. If there is no explanation, then let's move to the other point. If the head passes too quickly through the pelvis during delivery, it brings about compression, followed by sudden release of the pressure of the head. I think that one is self-explanatory. Rapid delivery brings about intracranial hemorrhage. Delay in delivery results in congestion of the various sinuses of the brain with anosmia, which will be seen as asphyxia at birth. The tentorial tears usually involve the great vein of the gallon and its functions of the confluence as the sinus. This results in intracranial hemorrhage. So this one too, I think with the excessive molding on all those things and with tears of the various sinuses and all those things, when there is tears, I think there will be bleeding. So it will lead to intracranial hemorrhage. Please, if anyone has additional information, the person can add. If you aren't clear with the explanation too, you can let us know.
So we'll continue.
Okay. If the delivery is slow, there will be compression on the fetal cord when the head enters the brain. And this will arrest the fetal circulation. The venous sinuses are fragile, therefore, when there is anosmia, they break. Therefore, when the delivery is rigid or slow, there will be intracranial injury. So with this point also, I think when the body is out and the head is inside and it's not delivered earlier, we all know that even though the baby's body is out, so the cord connects to the placenta. So if the head is in the brain, definitely it will compress the cord. And we know that it's the cord through the fetus get its circulation through the cord. So if the cord is compressed, circulation will be impaired. And when circulation is impaired, there will be low oxygen to the brain. That one too can lead to intracranial injury. Please, is it okay or sisters, please, is the explanation okay?
So we will manage it like that.
Yes, sister. Thank you.
Okay, so if someone has additional information to add, the person is free to do so. Okay, so another point. It says there could be prolapse of the cord because of ill fitting presented, and also because the cervical is closer to the breech and the umbilicus than the head. This one, can someone explain it for us? Sister Horacio, are you around?
Yes, sister.
Please help us.
Okay, so per my understanding, with this very point, normally when it is cephalic, the head is well fitting to the cervix than when it is breached. So with the breach, since the umbilicus is closer to the cervix with the breech presentation, it's closer to the cervical os. So it's easy to slip and then lead the presenting part. I don't know if you understand what I'm trying to say.
Yeah, we understand.
All right, thank you.
We understand.
Thank you.
Where's my phone?
Please, any addition?
Sisters, please, or let me explain it this way. The head is more rounded as compared to the buttocks or any other part that will be leading. So when the head is well engaged, it fits very well into the cervix, leaving no space for the cord to slip. But when it is in breech presentation, whether footling, presenting with the buttocks or whatever, it is not as the buttocks is not as rounded as the head. And the umbilicus this time around is closer to the opening. So once the buttocks doesn't cover the cervix entirely, it is not well fitting to the cervix. The cord is able to slip and become the leading part. Thank you.
Thank you very much.
Thank you.
Okay. So another point also states that there could be premature separation of the placenta during the second stage. Please, with that one too, any explanation?
Okay, so please, with this very point too, it's common in short cord, where when the umbilical cord is short and the presenting part is breech, mostly when the placenta is anterior, once the presenting part is advancing or it's being born through it's advancing, there is pressure on the placenta. The cord is short, the buttock is advancing, the cord will be pulling on the placenta. So placenta begins to separate prematurely. Even before the buttocks could be seen at the perineum and be delivered, the placenta would have separated already. Please, do you understand?
Yes.
Thank you.
Please, I hope you are all okay with the explanation. Sisters.
Yes.
Yes, we are.
Okay.
Okay.
Another point also say that when the body is born, the fetal head can inspire and inhale lipoamnitin with mucus and blood. That one that I think is self-explanatory. Okay. So another point also, if you aren't clear with the point, you can just voice it out so that we throw more light to it for you. Another point also said that fractures and dislocation of the spine, the long bones of the arms and the legs, and the ribs can occur due to poor handling or difficulty in delivering the body. I think difficulty in delivering the head, not the body. Please, with this one, is the explanation clear? Or is the point clear? Or do we need explanation?
Sister, please,
Yeah.
with this one, there are some of the babies. Let's take for instance, the baby is coming, presenting with the bottles. But at times the legs are extended upwards. There was one delivery I did, the legs are extended upwards, and the baby was locking the knee with the hands behind. And so with this one, delivery of the body becomes difficult because you have to follow, and then you flex the legs, deliver one leg, go and flex the other to deliver before you're able to deliver the bottles. I don't know if you can picture what I'm trying to put across. So when the baby is presenting with breech, your examination, vaginal examination, should be able to tell you the part that is present, whether it is compound or not. So when you are able to know the part that is presenting, then you will know how to deliver and handle the baby to prevent the injuries we are talking about. Thank you.
Please, I hope we are all okay with Sisters, please, are we okay? Hello, sister.
Hello.
Please, are we okay
Yes,
with
we
that?
are okay.
Yes, please.
Yes, please.
Yes.
Internal injuries of the liver or spleen or pancreas can also occur due to poor handling. That one too is self-explanatory. Nerve injuries. Else palsy can occur if there is too much pressure on the brachial plexus. So if you don't handle the fetus well and you have to compress the fetus so much, some nerves will be injured. Muscles injury. When the shoulders are possibly dragged out, there could be tear or bruising of the sternocleidomastoid muscles leading to torticollis. I think that one, when we treated torticollis in high risk, they explained it to us. So this one too is self-explanatory. Do you
Sylvia,
please? Yeah.
Sylvia, you
Yeah.
have like 4 minutes.
4 minutes.
Yeah.
Please, we have 4 minutes. Any question? Any questions so that we can address them?
Please, I think we can finish with this one before, like, with the explanation of these ones.
Mm-hmm. Yeah, not something. Okay.
Yeah, see a pan. I'm a book at you.
Is it not the reason why
Predate
you
before
like?
the 4 minute elapses.
So he likes this bread. And when it is finished, he's pointing eyes for an answer. Please, me and my children, we also like this bread.
Bruce's
Hey,
over
Ayana Al Hassan, mute your mic. Ayana Al Hassan.
bruising of the body or edema of the genital organs can occur due to pressure on them or congestion during delivery. That one too. I think
Please,
that one.
with that very point, especially it happens during vaginal examination. When the
Hello.
child is presenting with the bottles and you are doing V and you are not careful, you either insert your
Hello.
hello.
Hello. Good evening.
Good evening.
Good evening, Nadia.
Oh, how are you all?
Good evening, Ajia.
We are
Fine,
blessed.
thank you.
Well,
Yeah, fine.
How are you all?
Yeah, by the good.
I'm also managing. Yeah. I learned maybe the information that I gave to the lady did not. There was a miscommunication. She didn't hear me well. So she said it's 2 to 4, but it's rather 4 to 6 that I was talking about. So probably I don't know whether tomorrow. What do you have? Do you have lectures? But I'm sure you are done with the breach, and we are at the complications. Am I
No, we are
right?
done. We are not done. We are still on the we are on the reason for performing cephalic bracing.
Oh, good. Then you are still in the beginning now. Okay. Okay. So I think breach, because of the complications associated with it, there's the need for us to take our time and go through breach, because not only for examination's sake. I hope we are together.
Yes.
Yeah, I'm having very bad cold. So
It shows in your voice.
yeah. So I'm trying to see if tomorrow, what do you have in the morning?
Tomorrow we have abnormal pregnancy. But that's yeah, 11:45. Yes.
Okay. Okay. Then in the morning, what do you have?
You don't have
So
anything,
that
have
I can take about 1 hour of your time, and then we go through this thing. Because as for breach, every midwife should be able to conduct the breach in a way that is acceptable. Because it's not only for examination's sake, but practically, when you come face to face with breach presentation with a big baby, if you're not well versed with it, you end up causing a lot of complication, breaking the bones of the baby, causing fistula to the mother, all because maybe we are not knowledgeable in that field. So, what do you suggest?
Okay, Maja, then tomorrow in the morning.
What time?
What time will suit you? What time will it be? I like the way you have started. Rita, I'm so grateful that you started it. So where you have reached, since you have the slides, we'll quickly so that you'll be well versed with the bridge. And I can assure you, I'm promising you that I will video the conduction of bridge delivery when I'm well.
Thank
When
you.
I'm well, and I'm a bit relieved from the trauma that has overtaken me.
Want to see the compassion part.
Yeah. It was a big blow to me. In fact, it was a big blow for